So chapter 2 is physical agents in clinical practice. And the interesting thing I think about this course is that we're going to start here. We're going to talk about all the different modalities. We're going to practice them in the lab. And then we're going to come back around to this. How do we integrate these into our physical practice? And so I think it's interesting. So the learning objectives for this section are, I want you to be able to name 2 physical agents that have fallen out of favor recently, as stated in the APTA Choosing Wisely initiative. I want you to be able to describe the ICF model for rehabilitation, define evidence-based practice, which of course we've talked about a lot, describe guidelines for cost-effective uses of physical agents, and define outcome measures and give some examples. So functional outcome is really important in therapy in general, and particularly these days. So we're going to talk about that a little bit. So there's our outline. So physical agents have sort of been around for a long time. In the Western world, the ancient Romans and Greeks were kind of the first people who documented medical treatments. Before that, and also a long time after that, medical treatment was largely practiced in the home as in the form of folk medicine. And there's nothing wrong with folk medicine, but when we're trying to get into evidence-based treatments, we want to document what we do and how it works on the patient. So the ancient Romans and Greeks used heat and water to treat musculoskeletal and respiratory problems. In 400 BC, there's a documentation of using electrical stim from an electric torpedo fish to treat headaches and arthritis, which I think that's pretty interesting. Physical agents go in and out of favor in, I'm sure, ancient times and in modern times. So the APTA has published what they call the Choosing Wisely campaign. A physical agent usually falls out of favor either because the intervention has been found to be ineffective or because a more effective intervention is developed. A good example of that is the use of superficial heat from infrared lamps. It was a lot of times in the past, it was used to dry out open wounds. Well, now they know that wounds do better if they're a little bit not too dry, not too moist. So a lot of the wound care interventions kind of involve keeping the moisture of the wound at the right place. So we don't want to dry it out. We also don't want it to go in the whirlpool with it to make it too wet and macerate the skin. So sometimes more effective treatments are found, or things are found to be ineffective. So we know now that wounds heal more rapidly when they're kept moist, and so infrared lamps are not used to dry out wounds anymore. So a lot of times certain treatments were used, like using sun exposure for tuberculosis in the early part of the 20th century. Well, now we have antibiotics that treat that, and so that's not really used anymore. UV light is used to treat some wounds, and it's still used a lot of times in wound care settings, but you're not going to see it in general in physical therapy, even though we'll briefly talk about it at the end of the quarter. It's just a more specialized area of treatment now. So currently, heat has sort of fallen out of favor. The first of the 5 recommendations of the APTA Choosing Wisely initiative is, quote, don't use superficial or deep heat to obtain clinically important long-term outcomes in musculoskeletal conditions. So the APTA says, their statement is, there's limited evidence for the use of superficial or deep heat to obtain clinically important long-term outcomes for musculoskeletal conditions. While there's some evidence of short-term pain relief for heat, the addition of heat should be supported by evidence and used to facilitate an active treatment program. Active, that's important. A carefully designed active treatment plan has a greater impact on pain, mobility, function, and quality of life. There's emerging evidence that passive treatment strategies can harm patients by exacerbating fears and anxiety about being physically active when in pain, which can prolong recovery, increase costs, and increase the risk of exposure to invasive and costly interventions such as injections or surgery. So we want to get people active ASAP. It used to be when you got a total hip or total knee replacement, they would keep you pretty immobile. And this was 20, 30 years ago, or do passive treatments until you healed. And then they would do active treatments. Well, now they get you out of bed that day. A lot of times you go home that day. And you're in physical therapy 2 days later, working on active exercise, active treatments. So active treatments have been found by research and clinically to be more effective for healing musculoskeletal treatments. So when you look at what they say in the statement, and this is in your textbook, it does kind of say that heat can be used to facilitate an active treatment program as recommended in this book. So we're going to be talking about the application of heat and when you would do it and what sequence you would do it in the treatment. So sometimes heat can be a really effective way to facilitate your active treatment plan. So we're not crossing it off the list entirely, but we are not doing it as a primary intervention. Additionally, the second, another recommendation in the Choosing Wisely initiative is whirlpools. Don't use whirlpools for wound management. That used to be, that's how PT got into wound management in the first place. We had the whirlpools and they brought people in. So the APTA says whirlpools are a non-selective form of mechanical debridement. Utilizing whirlpools to treat wounds predisposes the patient to risks of bacterial cross-contamination, damage to fragile tissues from high turbine forces, and complications in extremity edema when arms and legs are treated in a dependent position in warm water. Other more selective forms of hydrotherapy should be utilized, such as direct wound irrigation or a pulse lavage with suction. So that whirlpools have gone out of favor. It's really not been that long since they've been out of favor, but you will not see a whirlpool in a PT clinic anymore. And one of the things that I think most PTs and PTAs hated about them, besides the risk for bacterial infection, they are a pain to clean. They are. You have to sterilize it and clean it after every treatment. And so therein lies the risk for infection. Plus, you have that medium that's getting into the wound, and that's not good. Plus, you're making the wound moist, and we want it to be moist, but not tissue damage moist. So really, the use of whirlpools for wound management has basically been removed from physical therapy. And now for in wound care, which we do wound care in a separate class, we'll talk about some of the other things we'll use for wound care. So sometimes physical agents lose popularity because they are cumbersome. It's a big machine or something that's difficult to use. They have excessive associated risks. They interfere with other aspects of treatment, or they're just out of style. Not the current thing. So a good example is diathermy. The old diathermy machines were huge. There were these big, like refrigerator-sized monsters with arms that had plates that went around. There are newer diathermy and shortwave machines that are much less cumbersome and easier to use. And you now will see them coming back into clinical practice. But for a long time, there are some risks associated with diathermy for the therapist and the patient. And so that is one of the reasons why they kind of fell out of favor. Now with smaller units and more manageable risks, you'll see it popping up again a little bit more. So we're not going to practice diathermy in the lab, but we will talk about the theory and the effects in the lecture. So there are lots of different approaches to rehabilitation. Really, we want rehabilitation to be goal-oriented and designed to maximize independence. So there are lots of different models that are discussed in the book. The linear model from the 80s, it's basically pathology or disease leads to disability and handicaps. And so we have to address the pathology or disease. The Nagy model focuses more on pathology and impairments. It focuses on what is wrong with the patient. The ICF model, which is kind of the current model that we are using, it views function and disability as a complex dynamic between health condition and contextual factors. It focuses on the patient's abilities, like what is right with the patient, what can they do, not what can't they do, but what can they do. So this is a little graphic of the model for the ICF classification of functioning and disability. So this is generated by the World Health Organization. So the health condition, disorder, or disease is affected by all these different things. So it's not linear. It's not a one-way street. It's affected by body functions and structure. That's the level at which the physical agents have the direct effect. And so we're trying to affect body function and structure with physical agents. There's also activity, participation, personal factors, which can affect all those things, environmental factors, and all of them are combined together to come up with your function. What can you do? So we can affect a few of those things. We can try to affect activity. We can try to affect body functions and structure. Environmental factors are a little bit out of our control. Personal factors, the patient might be able to affect personal factors. There might be things that are out of their control. They can affect participation, and all of that is going to affect their condition, and hopefully we can help them improve it. I always say to people that in physical therapy, we're not doing anything drastic. We're not doing surgery. We're kind of nudging people in the right direction. So that we're conservative treatment, and I'm all for that. So we're nudging people in the right direction and hopefully getting them a little bit better on improvement with their health condition and make the things that they can do greater and their disability lesser. So the APTA defines physical therapy and the practice of physical therapy. And their definition of the role of physical agents in rehabilitation is that without documentation which justifies the necessity of the exclusive use of physical agents and modalities, the use of physical agents and modalities in the absence of other skilled therapeutic or educational interventions should not be considered physical therapy. So physical modalities in and of themselves are not physical therapy. When you combine them with other therapeutic or educational interventions, that composes physical therapy. So again, we go back to the idea of physical agents as being tools in our toolkit. They're not the whole picture. So lots of different practitioners use physical agents. Of course, PTs and PTAs use physical agents. OTs and OTAs use physical agents. Athletic trainers do. Physiatrists, which are doctors that specialize in physical medicine. Chiropractors, acupuncturists, and patients themselves, the people that went on Amazon and got their e-stim machine. So every one of those people might have different goals and different training in the use of physical agents. So in order to make the physical agents part of our physical therapy practice, we have to define what our goals are, and we have to have a high level of training. So a lot of people coming into the physical therapist assistant program have worked or are working as PT aides in a clinic, or rehab aides in a rehabilitation facility, or nursing assistants, or athletic trainers, or exercise specialists. So we all are coming into it from a different point. A PT aide can adequately apply electrical stim or ultrasound or hot and cold treatments. And the main difference between a physical therapist assistant and a PTA is that we understand the theory behind it and we're able to adjust the treatment to address goals, to address effectiveness, and address the patient's reaction to the treatment. So by knowing the theory behind it, we have a lot of training, and we can adjust the treatment of the physical agents to better meet the patient's goals. So it's really important that we know the theory behind it. So a lot of what we're going to be doing in this class is studying the theory behind the physical agents. In the lab, of course, we will be doing the practical application, but the theory is a very important part of it. Evidence-based practice, of course, is the use of the current best evidence in making decision about the care of individual patients. I'll give you a non-modality example of this. As a lot of you know, I do a lot of neuro rehab, working with people with strokes and spinal cord injuries, and all of the therapists in the facility and the organization where I work, a lot of us are concerned with that. And just recently, some new evidence-based treatment has come up with gait training for people with CVAs through the Academy of Neurologic Physical Therapy. And a lot of the things that we've been doing all along, they're saying now you don't want to do that. We want to work on some other things. We want to work on walking training with moderate to high aerobic intensities. We want to do a lot of strength training and circuit training and balance training, and avoid doing some of the static or dynamic balance activities, including pre-gait, which we've done before. So all these things we've been doing for however many years we've been practicing it, all of a sudden we're having to shift gears and say, no, we want the evidence supports us doing something different. And we're all on board. We all jumped in with both feet and said, yeah, let's do it. High intensity aerobic training. So it's really interesting. Things change in rehabilitation, and you cannot be mired in your idea of what's the right thing to do. You have to realize that new evidence is going to come out and you're going to shift, which is great. And evidence-based practice is application of the scientific method. You have a hypothesis, you try it out, you evaluate how it worked, and you adjust your procedures depending on how it worked. So the goal overall is to provide the best patient care by assessing the available research and applying it to each individual patient. So evidence-based practice is where it's at. Can't talk more about it. So this is a little review. This is from the textbook, but we talked about this last quarter. The levels of evidence from highest to lowest, highest being meta-analyses, which is the highest quality, systematic reviews, randomized controlled trials, cohort studies, case control studies, and case reports. Those are all levels of evidence. Of course, the higher level of evidence, the more it proves that it's an effective treatment. There are things that aren't evidence. Anecdotal evidence is not evidence, saying I did this and it worked. That's anecdotal, like great that it worked for you. Clinical anecdotal evidence, like I use this on patients all the time and it works, that's still not evidence. A lot of our research starts there, like it's observed in the clinic and then somebody does research to substantiate that. However, one clinician's opinion is not evidence. So I've definitely run into clinicians that have strong opinions about certain things. Physical modalities is a very opinionated area. And opinions are great, but they're not evidence. So I know so many people that say to me, they go, well, my insert practitioner here, my physical therapist, my doctor, my aunt who's a nurse, my whoever says that this is the right way to do it. That is not evidence, that's hearsay. So let's make sure we're going with the best available evidence. So clinical practice guidelines are systematically developed statements to interpret current research. So the APTA clinical practice guidelines are based on that. And clinical practice guidelines give recommendations for diagnostic and prognostic measures for preventative or therapeutic interventions. So one of the things we're going through in my clinic right now is we're trying to establish appropriate treatment durations for different diagnoses so we can maximize our patients' time. And we are using the APTA clinical practice guidelines as a guide for that. So within different healthcare delivery systems, we are always pressed to use resources in the most cost-effective manner. Reimbursement has been reduced across the board for physical therapy and for a lot of other things. So insurance companies aren't reimbursing as much. So the people we work for are getting paid less, and that affects us, of course. There's increased requirement for documentation. There is increased requirement for assessment of functional outcomes in response to interventions. So early on, the model was we got paid for time. So you spent this amount of time during this intervention, and that's what you got paid. Now they're looking for functional outcomes. So we get paid for outcomes more than getting paid for time. So we want to do everything in a cost-effective way. So in order to be cost-effective in the use of physical agents, we want to assess and analyze the presenting problem. We want to know when physical agents can be an effective component of treatment, know when and how to use the physical agents most effectively, know the skill level required to apply the different physical agents. Is this something that you need someone who's certified to do it, like mechanical debridement, or is it something that anybody can do? We want to optimize the use of different practitioner skill levels, and we want to use home programs when appropriate. So what can the patient do at home? We want to treat in groups when appropriate. We want to reassess patients regularly to determine the efficacy of the treatment provided. And basically, we're reassessing at every treatment to determine the efficacy. And we want to adjust the plan of care according to the findings of the reassessments. So if we're finding a certain, there was a certain physical agent in the plan of care and we're not getting the results that we wanted, we're going to switch it up and adjust the plan of care. So I'll give you a clinical example that I think embodies this pretty well, one that from my own experience. So a patient came in for evaluation of a gait problem. The physical therapist evaluated the person's gait, and they were currently using a certain type of AFO, and the physical therapist thought that maybe a different type of AFO would better serve them and improve their gait. So the limitations that the patient had to getting into the new type of AFO is they had a plantar flexion contracture in their ankle, and they had to be able to get to neutral dorsiflexion to get into that new style of AFO. So the PT thought it would be effective to use instrument-assisted soft tissue mobilization to affect the collagen tissues in that area to increase ankle range of motion to get the patient into the AFO. So trying to optimize the use of different practitioner skill levels. That particular physical therapist isn't trained in instrument-assisted soft tissue mobilization because they're a neurological and gait specialist. I am trained in that, and so they put the patient on my schedule to for a few treatments to try to get to that. We started with ultrasound to affect the collagen extensibility, and then did instrument-assisted soft tissue mobilization and high rep, low load strengthening exercises for the dorsiflexors and stretching. And after a couple treatments of that, we were able to get the patient's ankle to neutral dorsiflexion, and they were able to get on the brace. So that was pretty effective use of physical agents, the skill level required to apply the physical agents, optimizing the use of different practitioner skill levels. So once we got the restriction, the motion restriction taken care of with the physical modalities, then we got the person in the brace and they were back on the primary PT schedule, working on learning how to use that brace more effectively to improve their gait. So it was a really good, and the other consideration was that the person had limited insurance coverage, so they only had a certain number of visits. So we wanted to maximize the use out of the number of visits they had. So we did 2 treatments with the physical modalities, and the rest of them were gait training. So the person was able to get what they needed in less amount of time because we applied a cost-effective use of what we had. So that's a good example of that. So outcome measures are used as an attempt to assess functional outcomes in response to different interventions. The goal of any intervention should be to obtain the best outcome for the patient. So functional outcome measurement tools, they can serve many purposes. And they include, the purposes of using the tools include, but are not limited to, helping goal setting, providing motivation for the patients, helping to guide treatment, providing a prognosis for a specific condition, or to provide justification for treatment. So one of the things when you do a functional outcome measurement tool like the 6-minute walk test or the bird balance scale, that can help in goal setting. You're saying, well, this is specifically what they're not good at and they need to work on. It can provide motivation to the patient when they see improvement in those areas. And you can, a lot of times you have to point it out to them. People feel like they're not improving. You'd say, well, look, when we first started, you couldn't do this and now you can. That's good motivation. To help guide your treatment, sometimes you say, like, okay, let's see, what am I going to do today with this person? Okay, here are their goals. Here's where they were lacking on their functional outcome tool. That's what I'm going to work on. And providing a prognosis. So let's say that at the initial evaluation, the physical therapist did the Berg balance scale, and they scored a 40 out of 56. So the Berg has a lot of research behind it, and 40 out of 56 indicates a high risk for falls. So that's their prognosis, is that they have a high risk for falls. And it justifies that we need to work on that to lower their risk of falling. So falling is one of the things that is an indicator of disability and early death in older people. So avoiding falls is a good idea. And we're using our functional outcome tool to help us design our treatment to do that. So some examples of functional outcome tools include the timed up and go test, 5-time sit to stand test, Berg balance scale that I was just talking about, 6-minute walk test, functional reach test, the Oswestry low back pain disability questionnaire. So the first 5 that I listed there are tests, measurements that we take in the clinic. The last one is a subjective questionnaire where the patient is reporting their function. And so in our clinic, we, as a group, get together and we decide which functional outcome tools we are going to use for which diagnoses. So if somebody comes in with low back pain, in their intake paperwork, they do the Oswestry low back pain disability questionnaire. One of the goals is set to increase their score by a certain amount. And then when we're doing progress notes or discharges, we retest the Oswestry and we see if they've met that goal. So you definitely want to use functional outcome measurement tools that have good research that supports they evaluate what they're supposed to evaluate, and there are lots of them out there. So you can go out and look up the timed up and go test and the 5-time sit to stand test and see. The other thing that the evidence-based tools have with them is they have age-related norms that you can look at and say, well, my patient is good compared to their age-related norm, or they need some work on this. It's something something that they need to work on.